Welcome to the PAA Clinical Training Series, Home and Community-Based Services, HCBS Settings. The agenda for today's training includes a review of the person-centered service plans, a discussion around the HCBS setting requirements and how this overlaps with your clinical work, a review of how to use the new HCBS settings tool, conversation around what is a modification and documentation examples of modifications, and finally some best practices. Before we talk about home and community-based settings and the characteristics, we're going to do a quick review of the person-centered service plan. Before we talk about the HCBS setting requirements, I want to review some highlights from the person-centered planning training. It's important that we review this before we talk about the setting requirements because the person-centered plan kind of sets the stage for then ensuring the setting requirements are integrated into the care plan where appropriate, that you are then having those conversations with the individual. And so reviewing this first will really help set us up for the rest of the presentation when it comes to the setting requirements. So as a reminder, the federal regulations require that we have person-centered planning processes where the individual and the people of their choosing are directing the conversation, leading the planning process where possible. It will reflect any cultural considerations and include strategies during your conversations to solve conflict or disagreement where it's needed. It's part of offering choices to the individual regarding the services and supports that they receive. And then another requirement is that the plan contain particular components or reflect the particular services and supports that are important to that individual to ensure that they are meeting their social needs, their clinical needs, support needs, etc. The plan needs to reflect the strengths and preferences of the individual. The plan needs to include those identified goals and the desired outcomes. It needs to include natural supports who will help them meet those goals, but also include the services or providers that will also help them meet those goals. And those providers, those services, those are where the HCBS setting components kind of become integrated into your conversations with the individual and integrated into the plan itself. And that's why we want to ensure that you understand the planning process and development first before we talk about the settings. So each of the providers or the settings that are providing these services to individuals have to meet additional setting characteristics that we're going to get into. Please note that like the other training, person-centered service planning includes both the care plan and the service plan. Next, we're going to talk about the specific setting criteria and how it impacts your clinical work. So to review again, home and community-based settings are settings that include private residence, assisted living facilities, and adult day centers. So when we're talking about these home and community-based service setting requirements, these are the three settings that you should keep in the back of your mind as we're going through the presentation. These are all places where the waiver services are delivered. Home and community-based settings are not hospitals. They are not nursing facilities. So there are specific qualities or characteristics that each three of these settings have to meet. And again, it applies to every person-centered service plan, regardless of whether an individual is on the passport or assisted living waiver. The home and community-based settings have particular characteristics or qualities that have to be met in order to comply with the federal regulation, with the waiver, and this includes both individuals on the passport and assisted living waiver. So part of developing a person-centered service plan or the care plan includes that both the PAA clinical team and PAA provider oversight team are either having conversations with individuals about these setting requirements or monitoring the setting for compliance with the setting requirements. And together, that work will ensure that the federal regulation requirements as it relates to the setting is being met. Now, there are individuals who are on passport who are not receiving adult day services, who are already presumed to be in a setting that is home and community based and meets the requirements in the rule. And we'll talk about how to reflect that documentation in the care plan in just a moment. But in order to ensure that every case manager has an understanding of each of the setting requirements, we're just going to review those requirements one by one so that you know what is the expectation for your conversations around developing that person-centered care plan and including the home and community-based conversations during those conversations that you're having with the individuals. So the setting has to be integrated into the greater community, and what that means is that the setting or the living arrangement has to include opportunities to seek employment or volunteer in competitive integrated settings. It means that the setting facilitates engagement within the community to the extent that the individual desires or prefers, that they have the ability to control their own resources. Now, when it comes to that one, I know that if an individual needs help with managing their finances, that a implication will be generated in PIMS or that it will be care planned, but it is also captured in the settings requirement as well. So it is a little bit of a duplication. And that the individuals receive services in the community to the same degree of access as individuals not receiving Medicaid. Now that particular piece about community integration isn't on this slide, but it is going to be reflected in the tool that we're going to go over in a little bit. Let's go over the rest of the setting requirements. The next is that the setting is selected by an individual. Now again, you have likely already had that conversation during your care planning process, and that individual is given choices, and that those choices, where appropriate, are documented in the care plan and are based on the individual's needs and preferences. And for those who are living in an assisted living, additionally, that those folks have the option for a private unit in the assisted living, and that they have the resources available for room and board. Again, we're going to talk about how to reflect that in the documentation in a bit. Next is that the setting or living arrangement ensures an individual's rights to privacy. Additionally, it includes privacy, dignity and respect, and freedom from coercion and restraint. The setting optimizes independence. And this also includes that the setting does not regiment individual initiative, autonomy, and independence in making life choices, including but not limited to daily activities, physical environment, and with whom to interact. And lastly, the setting facilitates individual choice regarding services, supports, and providers. So again, the individual choice regarding services and supports and who provides them. This is an example of what we would expect to see in a care plan for somebody who is on the passport waiver, who is not receiving adult day services, but would possibly be receiving personal care and home delivered meals, for example. The implication has that language HCBS settings in front of it to help ensure that you have that information captured in the care plan. It just keeps it organized and easy to track and to ensure compliance. Every individual who's on the passport waiver, regardless of the services that they're receiving, has to have this conversation with the case manager. So your responsibility is to go over those setting requirements and make sure that the individual understands what they are to the extent that is appropriate, and that the care plan reflects that that conversation occurred. So this example on the screen essentially demonstrates compliance with the waiver requirements, with all of the federal regulations and the Ohio Administrative Code. This is very general information. It includes that Sharon is in her own home, receiving passport services, will have autonomy, choices, all of her rights adhered to, and that the settings requirements will be reviewed at least annually, if not at every in-person visit as appropriate, and that any changes regarding the needs of Sharon will be discussed and reviewed with the case manager to ensure health and safety for Sharon. So again, this is a very plain example of how the case managers, how all of you will reflect that you have met the requirements of the HCBS settings in your person-centered service plan. Next, we're going to talk about the new HCBS settings tool that is going to go into effect as of today. This is a new tool that ODA developed, which replaces the Ohio Department of Medicaid checklist that you were using up until this point. The Department of Medicaid had two checklists, one for residential and one for non-residential. You are no longer going to use those checklists and instead replace them with using this checklist. This checklist is just one page and includes residential and non-residential settings. It's been reorganized so that it's a little bit easier to follow and is more in alignment with the rule language. This tool is to be used for all waivers for individuals who are in their own home, private residence, who are in an assisted living, or who are receiving adult day services. Moving forward, you are no longer required to document that you have utilized this tool in PIMS, and you do not need to keep a hard copy of this tool, but you may continue to do both of those things as best practice or as directed by PAA leadership. This tool should be used at least annually when you are reviewing the settings requirements with individuals, but you can also use it when you're having your in-person check-ins, if there's a change in condition, whatever the frequency is per the rule, you can use this tool at any of those points. The tool is broken up into three different sections. The first section at the top, it says HCBS settings applies to all waiver services. That is a summary of the setting requirements that we just reviewed in the previous slides. This is applicable to passport and assisted living waiver. There are directions in each of the sections to help remind you of what the expectations are about the requirements. And then the second section, HCBS settings, is only for adult day services and assisted living services. These are the additional conditions or characteristics that are required for provider-owned or controlled, also known as assisted living or adult day services. And these are broken down one by one, and you'll get a review of those as we move through the presentation here in a little bit. And then finally, the modification documentation requirements at the bottom are broken out so that they align with the rule as well, and it explains what do you have to have in your care plan when a modification has been identified. So again, this tool is meant to be user-friendly. It's designed to combine several requirements of the settings rule and is not going to be required to be put into PIMS or that you have to keep a hard copy. I encourage you to have this tool handy or open on your desktop while we go through the rest of the presentation so that you can see the flow of the tool. It might help to take any notes that you need, but keep that tool handy as we go through the rest of the presentation. So the next several slides are going to be the additional conditions that provider-owned or controlled settings have to meet. So these are the assisted living facilities and adult day services, adult day centers. The additional conditions are outlined in rule, and I want to go through what they are first, and then we're going to talk about how you would document any modification to these setting requirements. So first, the living unit is a specific physical place that can be rented or occupied. Now this is specific to specific to assisted living. You are going to see the provider type or provider setting called out on these slides as well as on your tool so that you know which setting requirements are applicable to adult day or assisted living. There's been some confusion around that, so we wanted to take that additional step and ensure that you knew which of these setting requirements or conditions are appropriate for which setting. Now, this particular setting requirement is going to be verified or monitored or reviewed by the PAA provider oversight members, staff, and they are going to be looking at the resident agreements or admission agreement. There's lots of different language that we use, but know that those additional requirements are going to be verified for compliance by the provider oversight. I wanted to put this slide on here just so that you know it's a requirement of the setting. You don't need to do anything about it, but if you are hearing of concerns from the residents, the individuals, that they are not having a resident agreement, or if they have questions about the resident agreement, by all means you can look into it. But if there are issues, we are asking that you talk to your PAA provider oversight staff, talk to your PAA leadership, and develop any internal processes that might be necessary to address those issues. Of course, ODA is always able to help with that as well. The next setting requirement is that, and you'll see it here on the snapshot of the tool on the left side of your screen, is that the living unit has a door which is lockable by the individual. Now you see here it says adult day and assisted living. Assisted living is pretty obvious, that the individual can lock their door to their room whenever they want, and that they have a key to unlock that door. The reason why adult day has been added is because when CMS came out to do on-site visits to review the state's compliance with meeting these additional setting requirements, they had found that an adult day provider did not put locks on the bathrooms, and the individuals that were being cared for at the adult day center all had dementia, which is fine, but the problem was that the individuals whose service plans or care plans were being reviewed did not have any modifications to reflect that they couldn't have a lock on their door. And so CMS said, well, if you're going to remove a lock from the bathroom for safety reasons, then it needs to be in the care plan. So as many of you might be familiar with, you had to go back and update your care plans so that if an adult day didn't have a lock on the bathroom, there was a justified need in the care plan, also known as the modification, and make sure that the adult day center was given an updated care plan to reflect that. I also included some observations on these slides to help give you a sense of the things that the provider oversight staff are looking at when they do an on-site review. These are things that I'm not necessarily saying you need to look at, but it might be helpful if you are seeing issues with meeting these setting requirements to notify the provider oversight staff, because they can then investigate and figure out whether there's an additional step that needs to be taken with educating the provider, and take it from there. Individuals having a lock on their door means that there should also be appropriate staff who have a master key. So in the event that an individual loses their key, they can ask a staff member to open the door for them. Again, not something that you need to necessarily ask about, but if you're hearing concerns from an individual when you're doing your in-person quarterly visit and they're talking about everybody coming into their room using a key, it might make you want to ask some more questions, investigate a little bit further, or talk to your provider oversight staff. Next is that the individuals who are sharing a living unit have choice in their roommates. So an individual, as you all know, has to have a pre-existing relationship, and a roommate has to be authorized in the care plan by the case manager. I put a modification required under there because anytime you are having an individual with a roommate, it has to be in the care plan. It has to, be represented that the existing relationship existed and it's documented in the care plan. So by default, the modification has to be in the care plan. Obviously, there's not going to be a roommate in an adult day, so that's why you just see assisted living. Next is that the individual has the freedom to furnish and decorate their sleeping or living unit within the lease or legally enforceable agreement. And this is applicable to assisted living facilities. Again, the PAA provider oversight staff are reviewing that lease agreement, resident agreement, whatever you want to call it, to ensure that that language exists. But you need to ensure that your individual is aware that they have that right, that they can choose to bring artwork, family photos, other items from home into their assisted living, into their room. You would also want to remind them they can bring bedspreads, other lounge chairs, dressers, things like that. If an individual is telling you they can't, again, bring that to the attention of the provider oversight staff, or you could talk to the provider if there's a miscommunication about meeting those expectations. Again, we encourage you to work within your PAA leadership to develop internal processes for communicating issues between the PAA clinical staff and the PAA provider staff when it comes to setting requirements. Next is that the individual has the freedom and support to control their own schedules and activities. This is applicable for both adult day and assisted living facilities. Things that you would see to ensure that an individual is given these opportunities would be choice in when somebody wakes up, when they want to go to bed at night, that they have the freedom to skip an activity if they're not interested, that they are not forced to participate. That they can eat meals in their room. They don't have to eat them in the dining room with everybody else. That they can attend activities outside of the facility, whether it's the adult day or the assisted living as desired. Staff should not be required to accompany an individual unless a modification is identified in the care plan. So for somebody who has late stage cognitive impairment or some other cognitive impairment that requires safety or supervision, you would want to add a modification, as that would be a change in the setting requirement for that individual. Again, attend outings with family and friends, and if they are on a secured memory care unit or secured adult day where they can't just leave the setting, that again, a modification would need to be reflected in the care plan for those safety concerns. That the individual has access to food and snacks at any time. This is for both adult day and assisted living facilities. And what this means is that the individual can access snacks independently, so they do not need to find a staff member who then has to unlock a door to get to the snack area. Snacks need to be available at all times, in between meals, at 3 a.m., whenever. And that individuals can keep food, they can keep snacks in their own living unit if they're in an assisted living facility. They should be able to access snacks and food outside of kitchen hours. So again, if somebody is hungry at 2 a.m., they should be able to request additional, I don't know, maybe it's a sandwich or something or some juice, but they need to have access at all times. Individual has the right to visitors of their choice at the time of their choosing. This applies to both adult day and assisted living. Visitors should be unrestricted in terms of when they can visit and where they can visit, unless there is going to be a reason that is assessed and justified in the person-centered care plan. We have heard of a handful of assisted living facilities since after the public health emergency ended that are still restricting visitation, and that is not allowed. We have to ensure that there is 24/7 access for visitation for those in assisted living, and that if you're in an adult day, you can have a visitor during the day. If you want the visit to occur in the individual's room, that right is provided to the individual, or if they want to meet in a common area, that they can do that. Again, if you see signs when you're visiting somebody at either setting types, adult day or assisted living, that say visiting hours from 9 to 5, that's a problem. That's a violation of the setting requirement, and we would ask that you notify the PAA provider oversight staff or talk to the provider directly. But again, please establish those internal processes with PAA leadership as appropriate. The setting is physically accessible to the individual. This is both for adult day and assisted living. So things like having grab bars in the bathroom, grab bars in the hallway, being able to move throughout the facility without any barriers. We would expect to see all of the physical accessible items within each setting as appropriate. Next, I'd like to have you watch a video about modifications. And I found this video, it's from Colorado's Department of Health, and it does a really nice job of explaining how person-centered plans are developed, how a case manager ensures that the process for developing that plan is person-centered, that the individual is leading the conversation, and that the setting requirements are reviewed and that modifications are reflected per this individual's choice. So while there are specific resources about Colorado, you can ignore those, and I want you to pay attention to the process of how the case manager worked in conjunction with the individual to meet their healthcare and safety needs. Because I can't play this video through this PowerPoint, I'm going to ask that you press play on the video and watch it all the way through before proceeding to the next slide. Now that you have an understanding of what modifications are, at least through the lens of the individual who's receiving the waiver services, I want to talk about the work that you as case managers need to be doing when it comes to identifying modifications and documenting modifications. One thing that we've received a lot of questions about is just what is a modification and when are modifications applicable. The Ohio Administrative Code, as well as the federal regulations, state that modifications to the additional conditions or additional characteristics for the settings that are provider owned or controlled, which are the adult day and assisted living characteristics, are what need to be reflected in the care plan. So if an individual has a concern about not wanting to lock their door like they did in the video, that is a right that would need to be modified for that individual and be reflected in the care plan. Again, these are only applicable to provider owned or controlled settings, adult day and assisted living settings, and they must be addressed in a person-centered service plan. So conceptually, to help you better understand what a modification is, what it applies to, where it needs to go, we wanted to take a step back and just talk more about modifications conceptually. They are focused on individual needs and outcomes. They are based on the person-centered planning process. So ideally, you would be developing and identifying modifications as appropriate during conversations with the individual, evaluated with the individual regularly. So modifications are not one and done. You need to evaluate whether a modification is appropriate at each visit as based on the individual's needs. Obviously, if somebody has a chronic progressive disease that will not be improving, then a modification is likely going to stay in place as the individual is continuing to receive services on the waiver. But there are going to be instances where an individual changes their mind about wanting a modification, or their health or preferences change. For individuals on passport and assisted living waivers, I want to point out that it is not likely that there are going to be individuals who are not receiving adult day services on the passport waiver, that they likely don't have modifications. I don't want to say that it will never happen, but typically in most situations, modifications are going to be found on individuals on the assisted living waiver, or in care plans for individuals receiving adult day services. Modifications are not focused on system outcomes. Basically what that means is they're not designed to be provider driven or have a medical model approach. They are not based on the staffing preferences or the staff that the provider, the staff who are providing the services. It is based on what the individual's needs are, based on a justified, assessed clinical need or preference. They are not based on generalized approaches or assumptions. So if somebody has, again, a history of seizures, we would not just assume that they don't want to lock on their door. We need to follow the steps during the person-centered planning process and the actual development of the plan to ensure that the individual is leading that conversation and that it is person-centered as it relates to any modifications. And like I said before, modifications are not necessarily one and done. They aren't always going to be restricted forever. So please make sure when appropriate you're revisiting these conversations with individuals and ensure that the care plan has the most up-to-date language as it relates to any modifications. The modification documentation requirements are outlined in the federal regulation and are outlined in the Ohio Administrative Code for person-centered service planning. There are 8 requirements, and I'm not going to go through each of them, but they are on that tool on that 3rd section towards the bottom, and outlines each of the components that are required whenever you are putting a modification in a care plan. These requirements are non-negotiable, and they have to be within some part of the care plan, whether it's an implication, an intervention, or the goal. So please review those and use your tool to ensure that you're meeting compliance with this regulation. And here are the other 4 requirements. One of the questions that we get is, how do care plans where individuals do not need any modifications, what do they look like? What is the language that ODA expects to see in a care plan when there are no modifications of the additional conditions or characteristics for the setting requirements for somebody who's receiving assisted living or adult day services? Again, to demonstrate compliance, that you have had the conversation with the individual, to demonstrate that the setting was reviewed, the setting requirements were reviewed. We are asking that you identify the HCBS setting conversation similarly to the example before by using the HCBS setting language, and that you call out that the modifications are not needed at this time, that Sharon will have unrestricted access, choices, autonomy, etc., while at the assisted living, and that you will review these requirements at least at every in-person visit with any changing condition, etc. And that again, the assisted living will inform you, or Sharon or her family will inform you of any changes to the needs of Sharon's health or safety, or if a modification is needed. So this is again a general example that you can use to meet the expectations that ODA has on reflecting compliance with the settings requirement in the person-centered service plan. Now that you are familiar with the additional setting requirements or additional home and community-based setting requirements as it relates to adult day and assisted living services, I want to go through examples of how to reflect any modifications to those setting requirements within the care plan or the person-centered service plan. And we have broken it down again by the setting requirement at the top, and I suggest you follow along on your tool just so you can see the flow of how to utilize the tool. We are going to start with the lock on the unit door, which was the first requirement that we talked about, and this is an example of unacceptable care plan language. It simply does not have information about the assessed need for Charles. There is no information about previous interventions that worked but failed. Again, and I'm going through the modification documentation requirements as a guide to explain why this care plan language is not acceptable. It doesn't explain the clear condition or the diagnosis that is directly proportionate to the modification of why he doesn't want to lock on his door. There's no time limits on when this will be reviewed, outside of just that it'll be reviewed regularly. And there is no assurance that this intervention will not cause any harm to the individual. So while you're developing your care plan, again, use that tool to ensure that you are capturing all of the modification documentation requirements. So let's look at an example of acceptable care plan language for Charles. So Charles expressed a desire to not have a lock on his unit door. He has a previous trauma and would feel safer if staff had immediate access to his room. Again, you see that HCBS settings at the implication to call out that it is a settings requirement. And this is an example of an individual who is given the right to have a lock on their door, but is asking for it to be removed. It's a specific individualized assessed need. While the previous interventions weren't mentioned here, it's because it is Charles' choice to not have the lock on his door, and that the description of the condition is that there was a previous trauma and that he would feel safer if staff had immediate access to his room. There are established timelines for when the modification will be reviewed. It says that the case manager will review this modification at each in-person visit and encourage Charles to contact the case manager if he wishes to change it. and also that there's an assurance that the individual will, that the intervention and support will not cause any harm to the individual. Next is that the individual has a choice in the roommate if they are sharing a living unit. Again, looking at your tool, you'll see that that is next on the list. Here's an example of unacceptable care plan language. Again, looking at the last portion of the tool where you see the modification documentation requirements. Why is this not appropriate or acceptable? It does not include information about having a specific assessed need, and by that we mean that there's information to really support that Arthur and Denise want to live together. It's just vague, and it does not have information about consent, and that this modification won't cause any harm. So let's talk about what good care plan language would look like. So here's acceptable language for choice of roommate. That Arthur requires assistance with several ADLs, including medication administration, as has decided to move into the assisted living. Arthur wants to live with his wife of 33 years, Denise, at the AL. And then the goal is that the individuals will live in the same living unit, and this will cause no harm. That sentence, "this will cause no harm," is required for every modification to those additional setting requirements for assisted living and adult day. That is required per the Ohio Administrative Code. That is required per the federal regulation. And then lastly, the assisted living will allow Arthur and Denise to reside in the same living unit as requested, and that it is going to be monitored quarterly, and that they have a pre-existing relationship. Again, looking at your modification requirements for documentation, including all of those components that are on your sheet, where appropriate, needs to be demonstrated in the care plan. Furnishing and decorate, again, unacceptable care plan language. It doesn't have enough information to meet the modification requirements in terms of documentation. And here is an example of acceptable care plan language when it comes to furnishing and decorating. Now, we don't typically see a modification when it comes to this right in a care plan, but we did receive a question about it specifically, so I wanted to provide an example. Again, in the implication, you see HCBS Settings, and then it says, Bob recently moved to the AL and wants to decorate his room with items from home. Bob has a history of having bed bugs at his previous home, despite receiving education about how to keep his home clean and along with several bed bug treatments. Bob will not have bed bugs in his AL living unit, and then you see that statement about this will not cause any harms. And the intervention is that Bob will not be allowed to bring his personal items from home to decorate his living unit. This includes bedding, furniture with fabric, etc. Again, the modification is demonstrated by there being a specific assessed need, which would be the fact that Bob has a history of bed bugs, and to protect Bob along with all the other residents, we have to modify his right temporarily to ensure that the bed bugs don't come into the facility and spread. The time limit is really important on this one. Again, making sure that it is not restricted forever, and working with Bob to figure out some other ways to bring things into his living unit to personalize it, to make it feel like home. So perhaps that's through donations or other means for Bob to get items into his room. The next several slides are examples of other acceptable care plan language for the setting requirements. Controlling own schedules. Now, this might be more typical, where you would see a modification for the right for an individual to control their own schedule or activity. If you are having an individual who has maybe a diagnosis of dementia and wanders, Again, I want to go back to the example that CMS called out when they were here doing their on-site compliance review at the adult day. They also noted that just because somebody has a diagnosis of dementia does not automatically mean that their rights are going to be modified. We have to demonstrate that the assessed need and the specific condition that's associated with that, or the specific behavior in which requires the modification. So here in this example, you'll see that Jamie has a diagnosis of dementia and wanders. We call that out specifically because that's the behavior that is going to essentially trigger the need for the modification. And we'll see here that he gets confused about where he is and tries to leave his home. Reminders on the door have not helped, nor has redirection. Jamie was found outside by a neighbor after he was missing for 30 minutes. The level of detail here demonstrates that the modification is needed because previous interventions did not work. Less intrusive methods did not work. There's a clear description of the condition, which is the wandering and the confusion, that is directly proportionate to the specific assessed need. There's going to be a regular collection of review of the data to ensure that the modification is still appropriate. There is a statement that this will cause no harm to Jamie and that it will be reviewed quarterly. Again, another example of acceptable care plan language. You'll see that this example includes the setting requirement for access to food and snacks. In this example, you see that Gladys has a history of a particular syndrome that includes her not being able to control the urge to eat. And so on top of that, with the diagnosis of dementia, that she forgets she has this syndrome has caused the overeating to the point of hospitalization. Again, it's very clear what the assessed need is. It's clear what previous interventions were used, that this intervention will be reviewed regularly, and how the assisted living can help Gladys meet her need of wanting to have snacks in between meals. An example of a modification to the setting requirement for visitation. Again, we kind of talked about this before, but here's an acceptable example of care plan language for an individual who has a history of dealing drugs in the assisted living. It's not just that he's dealing drugs, it's that there's also a history of drug abuse, and he has been asked to stop doing this on multiple occasions, has also been offered options for drug rehab, which he refuses. The intervention will be that George can't visit in his own room, and that any visitors that he does meet with will have to be in the dining room, and that this will be monitored quarterly. Again, looking at your tool for the modification documentation requirements is that George has a specific assessed need. Options were given about drug rehab. He's been asked to stop and he refuses. So this will be monitored quarterly. This will not cause any harm to George, and that the visitation will occur outside of his room. Now that we've reviewed the additional setting conditions or requirements for provider-owned and or controlled settings, which are the assisted living facilities and adult day centers, we wanted to also go over an example about whether or not a modification is needed for somebody who wants to smoke in their own room who's in an assisted living unit. So in this example, the individual recently moved into the assisted living, and they like to smoke in their bed every night before falling asleep. But the facility doesn't allow smoking anywhere in the building per their policies. Now, the individual did sign the resident agreement with a no smoking policy within that agreement. It's certainly acceptable for the care plan to reflect the preference of the individual to smoke, But the facility is saying, no, you cannot smoke in the room. You have to go to a designated smoking area outside the assisted living. So would a modification to the setting requirement for assisted living settings, would that be needed in the care plan? So in this situation, there are not any restrictions that are limiting the individual from receiving the setting requirements. There are no restrictions on the individual from smoking. The provider is not saying you can't smoke. The setting is allowing the individual to smoke, just not in their room. They have to move to an outdoor location. So to answer the question, is a modification needed in this scenario? The answer would be no, because there is no modification, there is no limit or restriction to any of the setting requirements that we just reviewed previously. This is a really good example of why familiarizing yourself with those additional requirements for provider-owned or controlled settings is so important, because once you know those requirements, it will then help you answer questions like this. Finally, we just want to review a few best practices when it comes to documenting in the person-centered service plan for HCBS setting requirements. Like you saw in several of the care plan examples, including HCBS setting language in your care plan when you have demonstrated that you've had the conversation with the individual, discussed it with the individual, it was in the implication. That is a really good best practice to, again, call out that setting requirement was met. Engaging family and friends as partners in care when it comes to identifying modifications and how natural supports can help meet those needs. Effective communication and coordination of care. Again, that kind of goes back to the basics of developing a person-centered service plan. When you are asking the right questions, when you are digging a little bit deeper, communicating needs of individuals, particularly to assisted living providers or adult day providers, coordinating information in person or through the person-centered care plan is really helpful to ensure that everybody is meeting the needs of the individual through the same lens. Reminder to be mindful of how you write your care plan, knowing that the individual could read it. So use their first names if that's how you prefer to write, and be person-centered in your language. When it comes to modifications, again, making sure that the language is person-centered, that you are ensuring dignity for that individual, particularly if an individual is going to be able to read the care plan, making sure that the care plan is appropriate and that it is person-centered. If you have any questions about this presentation, or if you have questions about setting requirements at all, please don't hesitate to email us at the email address provided on the screen. Thank you very much.